Morning, everyone. I'm Dr. Deepak Talwar, and I am from Metro Center for Respiratory Diseases. And we are starting this program, which is ALPHA, Advanced Lung Function Testing. And we are introducing it in a unique manner, where the program, which its first edition is going to be there tomorrow, is going to be a full hands-on with skill labs where you will be performing the tests, interpreting the tests so that you are ready to do from the next day in your daily practice. So many new tests have come up that now we can precisely not only locate the functional disease, but also the quality of disease as far as the lung involvement is concerned. There is a definite unmet need in understanding so many lung function tests which have mushroomed in the last 10 years. And I'm sure many more are going to come in near future. They are all assisting us in making therapeutic decisions, diagnostic decisions, follow-up and monitoring decisions in our day-to-day practice. So why we shouldn't learn them, why we shouldn't use them, but the only question remains is how to do it. And that's the aims of this ALPHA workshop, which is being done along with the help of our educational partner, which is CIPLA with this. And of course, this entire program is hosted by the MCRD faculty. And they are now very well versed with all these new machines which have arrived, which you are not only going to see tomorrow, but also you are going to use it. This unique program, which has been designed with the help of the brains behind this program from the CIPLA Medical and many other people, and including, as I said, that influenced by the ERS program pattern, where the theory part is kept on to an online session and the offline session or the physical session will only have demonstrations, hands-ons, and skill labs. And it's one day which is practically giving you the whole experience as to how you will be able to utilize in your practice. And you will be able to judge which particular machines you really need to have in your own clinic for your daily use and how you are going to use it. So to understand this entire big process of evaluating lungs in the labs, we have all these tests which are non-invasive. I think the beauty of all these tests are that they are non-invasive, they are very patient-friendly, and most of the times we find the patients are very happy to perform them and even understand why the tests, what the tests are telling, and of course, what is its usage in their day-to-day decision-making for the medications, which we can all explain them once we ourselves understand the tests. Now, this program has this 2 hours online module in which 4 basic tests which are being done, which are going to be discussed in its theory part. The first is we are going to talk about fundamentals of lung physiology and anatomy, which is related to our interpretation or performing various lung function tests, which we are going to discuss, which are not only advanced, but also novel lung functions. So one thing I think the disclaimer I will say is that we are not going with the spirometry because we understand all people who are joining this program are already doing spirometry. And perhaps even more than that, like lung volumes and diffusion capacities, and that we consider as a routine lung functions. Beyond that, whatever we are going to do are all advanced and, of course, tests which are called novel because they are in the process of being utilized in practice all across the world. And since it's already available in India, we will be also not only using them, but also trying to discuss tomorrow that how are we using it in our daily clinical practice. The second part is, of course, going to discuss about body box, which is, of course, a complex physics for medical physicians like us. And it will be made simple so that we straight on go to hands-on tomorrow on body box. Then we are going to talk about diffusion capacity, And then something to discuss further on would be on various other newer tests or novel tests which have come up, like which are like on the ventilation inhomogeneity, like lung clearance index and things like that. So their theory part will be discussed. The first part which I'm going to discuss today is lung physiology and structure, which is related to interpretation and performance of lung function tests in our daily practice. So can I have my first slide, please? And also, after this 2 hours program, there will be a 20 MCQs, and these MCQs will be given to you tonight itself, which you are going to answer them prior to coming to our center tomorrow morning, where we are going to start the program exactly at 9:30 a.m. So as I think very rightly, we have labeled this program as to back to school, because when we talk about physiology and anatomy and its fundamentals, it reminds us of our school. But very important is we are only going to revise those concepts which are essentials for us to interpret the lung functions in our clinical practice. Next slide, please. Next, please. Yeah. Do I have the control to do it myself? No. Can it be given to me? The control to change? Is it possible or no? Okay, let's forget it. So see, what's the purpose of the lung? Purpose of the lung is to provide, according to us, it is oxygen to the each and every cell of the body so that it can function normally. And for that, what we understand is that we need to provide oxygen to each and every cell. And for that, the lungs needs to bring in about 10,000 liters of air. No, please go back to the slide. 10,000 liters of air per day. Because body needs about 420 liters of oxygen and produces in return 350 liters of carbon dioxide. So it seems to us that lungs are primarily made to get 420 ml of oxygen into the body and to get the 350 liters of carbon dioxide out of the body. That's the function of the lungs, which is expected to happen with a VQ ratio of normal about 0.8. Now, to perform this tremendous task, the lung needs to bring in and also expel, as I said, nearly 10,000 liters of air per day. And we do know that for that, a size of lungs, which is just about 5 to 6 liters, needs to increase tremendously where this kind of a function can occur. And for that, the lungs are ramified with multiple bubbles like structures called alveoli, which has one purpose of increasing the surface area, and two, to make it so thin that this transfer occurs so quickly that there is no strain on the respiratory system to provide this oxygen and taking this carbon dioxide out. And for that, the surface area produced is between 60 to 100 square meters, which is more than that of a tennis court. So this intricate structure of lung has been made to accommodate this transfer and facilitate this transfer of oxygen and carbon dioxide smoothly to happen throughout our lifetime. Next slide, please. But one important point to remember is that always think that lungs are made to provide oxygen. Actually, a very important thing is lungs are made to provide oxygen, but their main tuning point is actually the carbon dioxide. Lungs always work to maintain a very narrow therapeutic margin of carbon dioxide in the blood. So it is always fine-tuning its function so that it is able to maintain the carbon dioxide. And oxygen, of course, we know that the cells will need oxygen, but the tuning point of the lungs or the respiratory system is actually the CO2. Unless and until the hypoxia becomes so much out of proportion that it goes haywire, most of the time, the breath to breath variation is primarily related to fine tune the carbon dioxide. And to do that, we have airways, we have blood vessels, and we have a gas transfer membrane. That is the interface where the transfer of gases will take place. So three important components: airways, the blood vessels, and the gas transfer. And the important part in the airways to remember at this point of time is that we have a 23 generations of the airways. It's really runs a very, very long distance, almost like 1500 miles or something like that. And it is continuously dividing in such a way that the initial part, which is considered as the conducting zone, has 16 generations. And after that, which is the respiratory zone, is from 17 to 23 generations. So these are the respiratory zones where the alveoli are in taking part in the gas exchange are connected to them. These are the two major part of it. But the other way to look at the airways is to look at the airways which are and the airways which are small. So somebody is talking. Mute. Please mute everybody. Please mute. Please mute. I think there is a sound coming from somebody's side. Please mute. Okay. So the other differentiation of this airways is from the purpose of what is their size. Are they large airways or the small airways? So conventionally, small airways are the ones which are less than 2 millimeter in size, 2 millimeter in size. Then comes the blood vessels, and although the air conduits are same for taking air in and for taking air out, but for the blood vessels, we have so much of mechanism where the one set of blood vessels will come in and take the oxygen, and another set will go and take this oxygenated blood and supply to the rest of the body. So here there is a reversal where an arterial system to the lung brings in the venous blood, and the venous pulmonary system actually carries the oxygenated blood to the rest of the body. So they are dual in number. And of course, you can imagine to match that 1500 miles of the airways, equal distance has to be traveled in particular numbers by both the arterial as well as the venous side of the pulmonary circulation. So there is a profuse vasculature in the lungs, which is both arterial as well as venous. And to top that, this entire exchange where it is supposed to happen is considered as the blood-gas barrier, which is the alveolo-capillary membrane, which is about 0.3 micron thick. And very importantly, it has to be so thin that the transfer occurs quickly, because the red blood cells actually gets almost about 0.3 seconds time to stay in that area where it has to catch the oxygen and carry it on the hemoglobin and quickly pass on so that it can go to the venous side of the circulation to go to the rest of the body. So that mechanism of transfer of gas of oxygen as well as putting back carbon dioxide into the alveoli has to be very quick. And this blood gas barrier or blood gas membrane or transfer, whatever we want to call it, has to be the very system which is intricate in a way where it should function well with the ventilation and perfusion in cohesion, where they work together. And they work together to oxygenate the blood. And oxygenation means a hemoglobin attachment of the oxygen, which is in the RBCs. Do you know that if the one RBC gets a maximum exposure to 2 to 3 alveoli, and in that time, which is 0.3 second, actually it is supposed to get enriched with oxygen so that it can supply to the rest of the body. And this entire intricate mechanism is to be seen how well it functions from the point we breathe in to the time it takes the oxygen onto the hemoglobin and then carried to the rest of the body. Next slide, please. Next slide, please. Yeah. So if you look at the quick points for this respiration, that the flow which occurs from the nose to the conducting zones is the connective flow. After that, it is by the diffusion all across the respiratory zones. Pulmonary artery pressures are kept very low, around 15 millimeter, so that a huge amount of flow can go easily per minute, which is about 6 liters. And the membrane is kept extremely thin so that it can easily transfer the gases. And as I said that very less time is there for this membrane to allow oxygen to quickly get loaded onto the hemoglobin in the RBCs. Next, please. Next slide, please. Now, if you look at this first part of it is taking the air from the nose into the alveoli, which is the ventilation. Play the video, please. So you can see that when the air goes through our nasal cavities and enters the trachea and the conducting zone to the respiratory zone, the lot of opposing forces are coming in to allow this to happen. And the first kind of opposing force which comes is the resistive forces in the airways. And this resistance in the airways is called rho. And since it is dependent on the volume, and if it is corrected for the volume, it is called SGO, specific GO, airway resistance, specific airway resistance, which is SGO or rho. This is the resistance. And resistance, as we know, is dependent on certain factors like the diameter of the airway, the characteristics of the gas, and the amount of resistance which has been put forward by the various tissues which are there in the airways. But they are the resistive forces which are trying to oppose the flow of air which is happening through our respiratory system. The second resistance, a second kind of impedance or second kind of opposition is being given by the respiratory system in the form of combating the compliance. So compliance is put forward not only by the chest wall, not only by the alveolar structures and the interstitium, but also by the airways. So the compliance, which is trying to again hinder the flow of air into the alveolar region, is being actually opposed by the structures in the airways and alveoli, which are the elastic structures, or also by the elasticity as well as the tissue viscosity of the chest wall structures, which are both trying to actually change this dynamics of flow in the air. So you can imagine that although taking a breath seems very simple, but it is actually trying to compensate for so many opposing forces which are being put forward in the form of resistive or a compliance kind of forces. Next slide, please. Next slide, please. Yeah. Coming to this ventilation, we check it by the spirometry, which is the most common test performed for the lung function tests. And what we determine in spirometry is the tidal volume, as well as the forced expiratory maneuver, which picks up the FEV1 as well as the vital capacity. But you can see clearly 4 volumes and 4 capacities from our physiology teaching. You have inspiratory reserve volume, tidal volume, expiratory reserve volume, and residual volume. And 4 capacities: inspiratory capacity, functional residual capacity, vital capacity, and total lung capacity. Anything related to residual volume cannot be tested by spirometry because spirometry procedure ends at the end expiratory reserve volume, doesn't go below that. So spirometry cannot determine residual volume, and residual volume being a part of total lung capacity and functional residual capacity cannot be determined by spirometry. So remember that FRC, TLC, and RV are the volumes and the capacities of the lung which cannot be determined by spirometry, and it would require us to do it either by a body box plethysmography or by the dilutional gas methods which are used for it. And these days, all of us are using primarily the body box methods for this. So spirometry ends at vital capacity as well as the some routine things which are related to expiratory procedure, which is the FEV1. Beyond that, you need to go on to your lung volumes. Now, in the lung volumes, there are certain part of the lungs which do not participate in the gas exchange. And that part is called the conducting part of the airways. And it is called anatomical dead space, which is about 150 ml. But beyond the conducting airways, there would be certain parts in which, although they are capable of performing the gas exchange, but do not participate in any gas exchange. Since anatomically they can, but physiologically they are not doing it, they are called physiological dead space. In a normal human being, normally anatomical and physiological dead space together is 150 ml, with contribution from the physiological dead space is not significant. This is very important concepts because in diseases, the physiological dead space tremendously increases. However, anatomical dead space does not change at all and remains the same. Anatomical dead space is determined by the Fowler's method, in which we use single breath oxygen, 100% oxygen inhalation method, or physiological dead space is measured by the Bohr's equation, which is dependent upon the carbon dioxide extrapolations. And that is again, most of the times we are doing physiologically in the physics calculations. Next slide, please. Now, when we talked about spirometry, this is, I think only I'm going to cover one or two things in this spirometry, because tomorrow we are going to start with some things to improve the spirometry practice, but not talking about spirometry is that whether you do a spirometry of A, B, or C quality, what does not differ is that part of the curve which is called as effort independent curve, which is the the last 2/3 of the curve, which is actually the part which is effort independent, because at that point of time, even if we produce more effort, it is not going to change the flow rates. And flow rates are only changed in the initial 25% of our expiration. And if the patient puts some maximum effort, you get A. If they produce a medium effort, they do B. And if they do low effort, they go to the C. Now you can see that if the patient does not perform the spirometry well, then the most of the part, which is actually the effort dependent peak flow, which is to be recorded on the spirometries, will all be low, indicating an abnormality, which is actually just because of the patient's inadequate effort being put in, or the spirometry not being done properly, which are the only certain things which we are going to discuss. But another important point is that the spirometry is primarily looking at large airways. So you can see that this entire upper part is actually the large airways. And if the effort has not been done well by the patient, this will be completely lost there. Now, when we come to the effort independent part, it has to be in the percentage of the entire curve which is being seen here. And if the curve is already truncated, then this value will be again of no use to indicate effort independent part, which is the part which is contributed by to some extent by also the small airways. And hence, the spirometry is a very poor indicator of evaluating small airways, but an excellent parameter to evaluate the large airways. Next slide, please. So one more concept which comes on spirometry is the dynamic compression of the airways, which we generally seen when there is diseases which have a reduced elastic recoil and loss of radial traction on the airways. Normally, when we exhale out, the pressure when we increase to exhale out will be primarily leading to airflow during the expiration. And this will be determined by the difference in pressure, what is there at the alveoli created by us in the forced expiratory maneuver vis-a-vis the pressure which is at the mouth, which is the atmospheric pressure. But in patients who have got elastic recoil abnormalities, like patients with COPD and emphysema, this airway mouth opening pressure does not become the determining point, and some point in the lung becomes the point which determines primarily the airflow, which is now dependent on the pleural pressure versus airway pressure rather than the mouth pressure. So when the pleural pressures become so positive, they will put in a point in the chest itself where the pressure in the airways and the pressure in the airway in the pleura is equal and will not allow exhalation of the air beyond that point, leading to accumulation or leaving behind a large amount of air in the chest, leading to what is called as dynamic compression or dynamic hyperinflation of the lungs. So a lot of air resides inside the chest because of this point which comes where the pleural pressure becomes so positive in these diseases during expiration, doesn't allow the lungs to empty freely. And at this point of time, this point where it happens is called an equal pressure point, which is the EPP. And more it moves proximally towards the airways, towards the distal airways, the more air is going to be left behind in the air, which will be ultimately reflected in increase in the residual volume, increased in the functional residual capacity of the patient, and hence decreasing the vital capacity to the extent where the patient's exercise capacity or capacity to walk is significantly reduced. Next slide, please. Now we said about word about small airways, which is considered as the silent zone, and it exists whenever the airways become 2 millimeter or less than 2 millimeter in size. MMEF or MEF 25 to 75 is generally considered as the area which is being contributed also by the small airways, and fall in it with the normal spirometry may be an indicator for a implication of the small airway obstruction or disease of the small airways. But for this, it is very important to see that this MEF, MMEF, MEF 25 to 75 or FEF 25 to 75, different terminologies are used for it, has been appropriately placed in this flow volume loop curve. You can see this. If this curve is not done well, if it is becoming like this, the first 25% is gone, all the calculations of 25, 50, and 75 will wrong. And that's the reason why the spirometry becomes most of the times not a good and a sensitive measure to look at the small airways. Next slide, please. So the principle which we use in evaluating small airways among so many which are available, the most easy and ready to use in clinical practice is lung oscillometry. Lung oscillometry, what it does is it gives a bundle of sound waves of different wavelengths from the mouth into the airways, where they reach up to the terminal part of this system, that is the alveoli. And the amount of opposition which this sound waves get on its path through the large airways, through the small airways, terminal airways, is finally determined by the transducer, which picks up the resistance patterns or the pattern of opposition which is happening at the various levels, which depends upon which frequency is going to which part of the lung. So different frequencies are used from 5 hertz to 20 hertz, and they can be delivered by two different type of machines, which are impulse oscillometry or a forced oscillation technique. Both of them will be shown to them tomorrow, and you will be able to do the test on both of them, and you will be also able to interpret them tomorrow. The difference between these two techniques is, in impulse oscillometry, bundle of all these frequencies, 5, 10, 15, 20 are sent together. And on the amount of obstruction, the amount of difficulty produced in traveling 5 hertz, 10 hertz, 15 hertz, 20 hertz is recorded back when it comes through the mouth, which has a transducer, and then differentially seen that the ones which are at 5 hertz, how much was the problem with them, and the one which is at 20 hertz, how much was problem with them. In FOT, all these are also given, but they are given in separate random manners. You may give 5, 20, 15, 10 in a random manner. So once this is given, then again it's the opposition being produced to that is picked up by the transducer. So by and large, the principle is the same. Only thing is the way this sound frequencies are thrown with the breath is different in impulse oscillometry versus forced oscillation technique. Next slide, please. So as I said that it's basically to look at the small airway resistance, because for the large airway resistance, spirometry still holds a very good gold standard to carry on with the diagnostic procedures in our daily practice. In this, we are using two major frequencies, which is 5 hertz and 20 hertz. And you can see that the sound waves, which are of short value, like 5 hertz, goes long distances, and the ones which are larger ones, like 20 hertz, go shorter distances. So large airways, central airways will be evaluating by the R20, that 20 hertz, which will be giving us resistance in 20 hertz frequency, which is primarily reflecting the airway resistance in the large airways. On the other hand, when we talk about R5, R5 travels throughout the airways from the trachea or from the mouth down to the alveoli. So it is primarily looking at the total airway resistance, or the total airway, the opposition which is happening in the entire airway process. So when we subtract the total airway resistance being produced by R5, and we subtract the one which was offered by the resistance of the 20, or by the frequency of the wave which was used, 20, then R5 minus R20 is what we are looking at, small airway resistance. So primarily we are looking at two frequencies, 5 and 20. And the idea is 5 being small, travels long distance, goes up to the end of the airways, while 20 being a large frequency, big frequency, is able to travel only shorter distances, only up to the airways, which are mostly up to the more than 2 millimeter in size, which are large or central airways. Next slide, please. Coming to another concept, which is compliance. Now, when we move the air through the ventilation into the lung, then the chest wall needs to move. Lungs needs to move to accommodate this air. And they have inherited tendency to oppose that. And that tendency is called compliance. Let me remind you all that compliance and elasticity are the opposite words. So when we talk about the compliance, you can see here that the chest wall has a normal tendency to go outwards, and the lungs have a normal tendency to go inwards. So lungs are trying to collapse, and the chest wall is trying to expand. This is the normal thing which is happening as far as the chest wall and the lungs compliance is concerned. And where both of them are equal, because they are negative to each other, one is trying to collapse, the other one is trying to expand, both of them where balance out each other is the point where the chest wall compliance and the lung compliance are negating each other and are equal, is a static kind of a situation which is created, which is at the level of the capacity which is called the FRC. So functional residual capacity is the capacity where the chest wall and the lung compliance are balancing out each other. At the top of the compliance, you can see where the lung is absolutely ballooned out, which is like this is the total lung capacity where the alveoli are totally expanded. They can hardly expand more, but they can collapse much more. On the other hand, at residual volume, where the alveoli have all become shrunken and small, like it is being shown here, At this point of time, they have no more collapsibility, but on the contrast, they can expand a lot. So you can use the terms of compliance and elasticity being opposite to each other. At a point when they are very compliant, they have very less elasticity. Where they have a lot of elasticity, they are very less compliant. And these are the two extremes of the curve which are occurring from the residual volume to the total lung capacity. And where it balances out each other, that is the functional residual capacity. Normally, the lungs compliance is about 200 mil per centimeter of water, and combined lung and thorax is about 110. It's very difficult to do evaluation for a chest wall or the thoracic compliance per se, because for that you need to produce a pneumothorax in the patient. So in clinical physiological conditions, if we need to determine the compliance, we will be doing compliance of the respiratory system or the compliance of the lung. And the compliance of the chest wall is primarily by subtracting the total compliance of the respiratory system minus the lung compliance. Next slide, please. So why is this compliance due to? Compliance is primarily because of the elastic properties of the lung. So when you breathe in, at that point of time, it is different. And when we breathe out, it is different. So if you look at the pressure volume curve of the lung, you can see that in inspiration and expiration, it is different. It balloons out. And this is called hysteresis. So it's not a linear line. It is actually two different sides of the balloon, and hence it is called that it is the hysteresis. And this slope is what is called as the compliance. So what are these elastic properties of the lung which are trying to oppose these movements of the ventilation? They are basically determined by the elastic tissue of the airways and the entire airways as well as the lung parenchyma. And in addition to that, it is the surface tension which is trying to keep the alveoli open. So compliance is determined by not only the elastic tissue, but also the surface tension, which is primarily being reduced in the alveoli by the surfactant, which is layering all the alveoli so that they can easily open and easily collapse and do not produce much trouble in opening and closing them during the ventilation, allowing the air in and allowing the air to go out with the carbon dioxide. Compliance is decreased in lung fibrosis and increased in pulmonary emphysema. We all know about it. And this curve, which is being seen here, you can see that, which is the curve of compliance, which is delta V over delta P, is actually shifts leftwards in emphysema and rightwards in patients with pulmonary fibrosis. Next slide, please. As I said that, the chest wall, it is very difficult to, understand the elastic properties of it. But the most important thing is it is always trying to open and open because it is trying to expand. So it is at a position which is not the resting position according to it if the all other forces are taken care of. And the chest wall, which tends to, get outwards, is actually balanced at about 75% of vital capacity, which is FRC being the equilibrium point, which we have discussed. And the static lung volumes, which we talked about, is the total lung capacity, the residual volume, the functional residual capacity. They are actually determined not only by the elastic properties of the lung, but equally by the chest wall also. So the diseases like obesity, kyphoscoliosis, all these, or poliomyelitis, neuromuscular disorders, the palsy of the diaphragms, all this are going to contribute to change the elastic properties of both lung and chest wall, and hence affect the static lung volumes, which are determined by the body box technique or by the washout methods, which we are going to discuss tomorrow. Next slide, please. Next slide, please. Yeah, and last part is the diffusion part. Now, the air by the ventilation system has been brought into the alveoli, and the alveoli, the function is the oxygen has to transfer the blood gas barrier, and the carbon dioxide has come from the blood into the air, and then finally ventilation has to wash out that carbon dioxide again. Now, this blood gas barrier is called alveolo-capillary membrane, and the diffusion which occurs through this membrane is determined by Fick's law. And it's basically dependent on many factors like surface area, partial pressure of difference of gases on both sides, oxygen and carbon dioxide, which are the two gases which are important for us, and also related inversely to the thickness of that alveolar capillary membrane, which is the thickness of that tissue. And another constant which is very important is which gas it is talking about, and that is called diffusion constant, and it is related to solubility and inversely related to the molecular weight of the gas. So it is different for oxygen as well as carbon dioxide. And that's the reason carbon dioxide diffuses 20 times more rapidly than oxygen. So that is why these carbon dioxide problems do not occur early in diseases, because the body is tuned to look after that very efficiently, and it has been made according to that, so that it is able to manage the carbon dioxide with a very fine tuning with 2 to 3 values up and below the 40 millimeters of mercury, which we are talking about. To check this alveolo-capillary membrane, what we most commonly use is a carbon monoxide, and carbon monoxide quickly gets loaded onto the hemoglobin, making it carboxyhemoglobin, and hence it is diffusion limited. So there is no other factor involved in, next slide, please. There's no other factor involved in loading carbon dioxide onto the circulation, and there is unlimited amount which can be loaded onto the hemoglobin in the RBCs, and hence it is a diffusion membrane which will be the determining factor for limitation of uptake of carbon monoxide by the hemoglobin in the blood. So that is why it is used for determining the diffusion capacity, because it is a diffusion limited gas. And diffusion will be meaning it that it is membrane dependent, what we are talking about, that is the blood gas barrier. And you know that blood gas barrier has got 6 things in it. It has got alveolar epithelium, it has got its basement membrane, it has got interstitium, it has got basement membrane of pulmonary vascular endothelium, it has got pulmonary vascular endothelial cell, and finally in the free blood it has also got an RBC membrane which it needs to cross, and finally combine it with the hemoglobin which is present in the RBC. So there are 6 different points in the transit where the oxygen needs to travel and the carbon dioxide needs to come out. On the other hand, another gas, which is nitric oxide, is the one which does not combine with the hemoglobin in the blood. So it reaches in a rapid equilibration across the membrane, and hence it is not diffusion limited, but it will be determined by the perfusion, the amount of flow which is occurring in the pulmonary vasculature. So it is dependent upon amount of the blood flow it is available, and hence it is perfusion limited. So nowadays we have that actually when we use both the gases together, that is carbon monoxide as well as nitric oxide, the two of them give the two different components of the perfusion, or the what we call as diffusion capacity of the lungs. So the capillary, the membrane part is being represented by carbon monoxide, and the perfusion part, which is by the vasculature, is being evaluated by the nitric oxide. So if we have time tomorrow, we are going to demonstrate to you this double diffusion method, which is a new technique which is brought in to distinguish whether the diffusion capacity which is decreased in an individual patient, it is because of the predominantly the membrane component which occurs in emphysema or ILD, or is it predominantly because of the vascular component, which is because of the pulmonary hypertension, pulmonary embolism, and things like that. Next slide, please. Next slide, please. Yeah. And lastly, coming to ventilation perfusion, we know that ventilation perfusion ratios are like where we need the so that we get good amount of oxygen in and a good amount of carbon dioxide outside. But this is got a gravity dependence. So it's the ratios are high at the top of the lungs and low at the base of the lung. And the difference between the arterial and venous partial pressure of oxygen is actually the difference of ventilation perfusion inequality. Next slide, please. Now, ventilation, which is supposed to be homogeneous, in when the disease starts in, and it sets in the peripheral of the part of the lungs, that is the small airways, or the airways which are more terminal, it becomes inhomogeneous. And this ventilation inhomogeneity is an early sign of lung disease, and which can be picked up by the newer test, which we are again going to discuss tomorrow. Next slide, please. And one of the important tests, next slide, please. Yeah, one of the tests is to do it by the what is called as washout methods, nitrogen washout methods. So on the top, what we are seeing is a multi-breath nitrogen washout. You give 100% oxygen, and the number of cycles required to wash out the nitrogen to a predetermined level is considered as the lung clearance index, which is again an indicator of ventilation inhomogeneity. Or the other one is where there is 100% oxygen given to see how much nitrogen is washed out in different phases, which is the step 1, step 2, stage 1, stage 2, and stage 3 and stage 4. And it determines what is called as the closing volume. This also will be discussed and shown to you tomorrow. Next slide, please. Next slide, please. Yeah. And work of breathing is perhaps, I think this is really the last slide, which just tells us the same thing, that you need to do a lot of work to get oxygen into the lungs and carbon dioxide out of the lungs. And this is primarily to overcome two kinds of forces, the viscous forces or elastic forces. Viscous forces comes into play during the inspiratory part, and it is increased in restrictive lung diseases like pulmonary fibrosis or chest wall disorders. On the other hand, the elastic forces are of more importance in increasing the work of breathing during expiration, and it happens in diseases like obstructive lung diseases like emphysema. Next, please. So to summarize the key concepts which I have discussed, and I took a little longer time than 30 minutes, is primarily because I tried to bring in all the elements of the ventilation, then the gas exchange, the work of breathing, ventilation, perfusion, their ratios, and everything together, which can be these days be assessed by the various lung function tests which are available, and we are going to discuss tomorrow. Lung structure and function is very important for a pulmonologist to understand, so that they are better able to interpret their lung function test and put them into their clinical practice. And it is not only just the spirometry, but the lung physiology expands a whole horizon of ventilation, perfusion, blood gas barrier, work of breathing, respiratory mechanics, airway resistance, compliance, and they all contribute to our understanding of what is going on wrong in an individual patient who comes to us in our respiratory practice. Thank you very much. Last slide, please. Next slide, please. Thank you. So pull down this slide. Stop sharing, please. Yeah. So with this, we have come to an end of the first part of this lecture, which took a little long. I will try to compensate by reducing the time in the second part, when I'm going to talk about oscillometry at the end of the program today. But we are going to move ahead with a body box for the lung volumes and diffusion capacities, and the theory part will be dealt afterwards now. So the next part is the body box, and that is going to be dealt with Dr. Loveleen Mangla. And over to you, Loveleen.
Thank you, sir. Thanks a lot, sir.